I would like to invite you to the first session, which is dedicated to SMA therapies. And this section is, of course, just a short overview in few hours, what new achievements regarding the therapeutic issues we have, and also other things regarding the access for new technologies regarding not only drugs, but also regarding the care at homes, which could be dedicated also not for adults, but also for children. That's why this session is quite complex. And the spinal muscular atrophy, as you know, in this years is giving new chances for patients, especially for children, and also what is new in many countries, also for adults. Today, I would like to invite few speakers from different countries, which will present you different new technologies and new achievements and standards of care. The first session, which is dedicated to SMA, will be opened by Professor Damjan Osredkar from Pediatric Clinic in University Medical Center Ljubljana from Slovenia. The first presentation was dedicated to novel treatment options for children with SMA. Welcome. The floor is yours.
Yeah, thank you very much. My name is Damjan Osredkar. I'm a pediatric neurologist from Ljubljana in Slovenia, and I would like to tell you something about the novel treatment options that we have these days for children with spinal muscular atrophy. So let me see if this works. Okay, so I'll tell you something about the opportunity we saw several years ago and how we reorganized ourselves, about the registry that we have established, and I'll briefly tell you something about SMA. You probably already know a lot about this disease, and I'll tell you something about the treatment options that we have and how we see the future for our patients. So hopefully, let me just see. This switching forward is not working very nicely, but I apologize. I'm sorry, but the slides don't move forward. Okay. So we are working in Slovenia, which is a country that has 2 million people. We are working at the University Children's Hospital, which is a tertiary center, the only center in Slovenia where children with spinal muscular atrophy are being treated. We are a hospital that has 200 beds with 13 departments and an intensive care unit. So after a few years ago, there were new information coming that that patients will be able to be treated with novel treatment options for Duchenne's muscular dystrophy and spinal muscular atrophy. We knew that these children have been treated in Slovenia on different locations, but we thought that we should reorganize ourselves with the aim that we should get better care for these children, as these novel treatment options would require us to know more about our children, and we wanted to, to improve the care for the children as a whole, not just by giving them novel drugs that will become available with time, but also that we would be able to give them the best possible care following the guidelines that were available at that time, and also that are changing constantly. We have found a team of engaged individuals who were involved in treating patients with neuromuscular diseases. And we also became part of the European Reference Network for Neuromuscular Diseases, which was also a sign that the work at our hospital is being carried out on a high enough level. So the way we reorganized our flow was that we, instead of the patients going and trying to find various specialists for their problems, we found we hospitalized the patients for 2 days in our medical center, and then all the specialists came to the patient. So the cardiologists, neurologists, pulmonologists, they would all come sequentially and visit the patients, and decide which investigation should be performed in our patients. And those were done during the day and also some during the night. And after a 2-day hospitalization, we would have a pretty good picture of where the patient is and what his or her problems were. And we would also then sit together and try to find the best possible ways of treatment for this patient. We also dedicated a medical nurse to become a clinical coordinator. So she was the one who brought all these doctors together, and she was the one who decided on dates and times, and so that all the work went smoothly. And so let me go forward. By doing so, we saw several benefits. Some of the benefits were for patients, and the other were for medical specialists. And regarding the families, we saw that this was, there was a reduced burden time-wise for these patients, because everything was much more effective. Also, there was a smaller financial burden for these families, because many of these patients would come from faraway towns that required parents to travel a lot before to see the specialists that their child required. And also, it was important that the specialists all came to see the patient, which gave us the option to provide tailored care. For example, the first patients who received nusinersen, some of them who were in the late stages of the disease could not receive it unless this medicine was given under general anesthesia, so we could decide, on procedures and on who will be doing what, and so that everything went really smoothly. And also, we knew, and the patients knew, that they were getting a unified care and following the best guidelines, which were evidence-based, obviously. And this also gave us the guarantee that we are doing the best that we can for our patients. And of course, following all this gave the patients the opportunity for a better outcome. So there were also benefits for the health professionals, and those were that we got better recruitment. We immediately saw that we would see all of the patients that sometimes would be missing some of the examinations before. It also gave us the opportunity to build the registry, which I will talk about later, but the registry is extremely important for having a good overview of all your patients, and also for the novel treatment options that are available, because many of those are now very specific to the genetic mutations that these patients have. It also gave us opportunity to collaborate with other registries, such as TreatNMD, which is kind of a registry of registries, but also with other countries, because we can share the data and try to find out the best possible ways of treating our patients. It also gave us the opportunity to collaborate in clinical studies, which I will show you a bit later on. And also, as I said, it gives the opportunity to treat these patients with novel treatment options. We also became the reference center for the whole region, which is also important, because some parts in our region are less fortunate to have all this care. So many of the patients from these regions will be coming to see us, and so they would get the care at our hospital. And also by optimizing care, this, we have to be also careful about the financial impact of all these novel treatment options. And by reducing and optimizing the care, we can actually help in that respect as well. So we set up a registry because we saw that before we didn't have a very good picture of how many patients we have, what kind of problems these patients would have, and what genetic background there is. So we could not, we knew that by these novel treatment options that will be coming, it won't be possible to provide it unless we will have such a registry. This was an ethics committee approved registry. It's a national registry, and the professionals enter the data because some of the registry are such that the patients are actually those who enter the data. And we also collect some DNA and RNA samples because that gives us a good opportunity to find some biomarkers that could potentially help us guide in future decisions on what treatments are best. There was no extra funding for devising such a registry, and we invite all of our patients, but the participation in the registry is voluntary, and if the parents write the informed consent, they can be enrolled into the registry. So this is a snapshot from our registry, and as you can see, we can immediately see what patients we have and the numbers of those patients. And for example, we immediately saw that looking at the incidence of Duchenne's muscular dystrophy, we ought to have more of those patients. So what we did is we immediately, tried to raise the disease awareness. We went out and talked to the, patients groups and to the lay public and also to primary physicians. And this way we could recruit actually more patients with Duchenne's muscular dystrophy. And obviously, what our registry also involves different SMA types, so we can immediately see what kind of patients we have just by looking, at the data in our registry. So I don't want to go into much detail describing spinal muscular atrophy, but I'll still give some information for those who might not know these things. So just so we know we are on the same page. So it's an autosomal recessive neuromuscular disease. It's the leading monogenic cause of infant and child mortality, as many of the patients, if they have a more severe form, would not live over the first year or the second year of life. As of now, the disease is not completely curable, but at least we can treat it now very efficiently. The problem with spinal muscular atrophy is that motor neurons are degrading over time. It is the neurons that connect the spinal cord with the muscles, so they kind of relay the information that the brain sends to the muscles. And this is caused by the lack of the spinal survival motor neuron protein because of the genetic mutation. And this leads to hypotonia, which means that the patients will be wheelchair bound with time. Many of the patients would also need ventilatory support with time, and the severe scoliosis can also develop, which can decrease the pulmonary function of these patients. And the problems with pulmonary with the lungs can actually be the leading cause of mortality of these patients. And as mentioned, these patients do have a shortened life expectancy if untreated. So I'd like to show you, and please can you turn the video on? Is that possible? Because I don't know if I can do it. Okay, even if there's no video, it doesn't matter. What you could see on this video would be that this child was a child with SMA type 1. She was hospitalized at our department, still at the time when we did not have any treatments available. And she was 6 months old on this video, where she has this bell-shaped chest. She had paradoxic movements of her chest, which means that during inspiration, instead of inflating the chest, the chest collapsed because it was so hypotonic. The muscles were hypotonic, and she was also fast through nasogastric tube. And although she could not move her limbs, at least she could not raise them from the ground, she was a very vivid-looking girl. And unfortunately, we lost this girl when she was at the age of 1 year. Sorry, this is... so the problem with in SMA is that the SMN1 gene is not functioning, and therefore the SMN protein is not being generated by the SMN1 gene. But fortunately, we humans have a very similar copy of the gene, which is called the SMN2 gene, and this gene is actually capable of producing about 10% of the functional protein. But most of the transcripts of the gene produce a protein that is rapidly degraded. And if you use these novel treatment options, such as nusinersen, for example, you can actually harness the SMN2 protein to to produce more of the SMN protein, which then changes the course of the disease. So generally, the more copies of the SMN2 gene you have, the milder the clinical picture of the patient, but it's not a one-to-one correlation. So as you can see on this picture, SMA type 1 patients, they can have either 1 copy, 2 copies, or 3 copies of the gene. And also SMN2 patients can have 2 copies or 3 copies of the gene, but some of them would also have 4 copies. So generally, we can talk about, we can generalize and say the more copies you have, the better it is, but we cannot always describe how severe the clinical picture of your patient will be just by knowing the number of SMN2 copies. So the first medicine that we could give to our patients in Slovenia was nusinersen. We got this medicine through the compassionate use program. So we gave it still before it was kind of registered in Europe officially. And this is an antisense nucleotide which requires intrathecal application. This means that you have to inject the drug in the cerebrospinal fluid through lumbar puncture, which can sometimes be a problematic procedure because these patients would quite often have scoliosis, and some of the patients would have severe scoliosis or they have already been operated for it. So the application is not a trivial thing sometimes. But we have found that nusinersen can actually very effectively stop the progression of the disease. And what this medicine does is it attaches to the SMN2 gene transcript and helps one of the exons that usually falls out when it's being transcribed. And therefore, this SMN2 gene starts behaving like an SMN1 gene, producing almost 100% of the normal amount of SMN2 protein. This is a picture of 2 of our patients, just kind of showing how severe the scoliosis in our patients can be. You have to inject in the level of L4 or L5, which is very low, just above the pelvis. But this is the region where also you could find metal rods which have been placed for scoliosis operation. And this can be, I think, this is something that you have to take into account when treating these patients. And together with our Czech colleagues from Prague, we have then collected all the data from our patients. And this is the summary slide showing how effective nusinersen treatment is in these patients. As you can see, for all SMA types, SMA type 1, 2, and 3, you would see an improvement on motor scales over the 14-month period of treatment. This is actually something that we couldn't observe before the era of treatment options for SMA patients, because those patients, the natural course of the disease would kind of predict that all of these patients would lose their motor capabilities. So for us, a successful treatment would be if these patients would not lose anything, but as you can see, even gained something on the motor skills, probably to the effect that some of the neurons were still in the process of dying, but this medicine was actually helping those neurons to survive and to regain some of the function. And what our study on, there were 61 patients that were analyzed in this study also showed, is summarized on this graph. And this is very important also. This is when you look at our patients after 14 months and deduct what they could do before starting the treatment. So those patients who would not, lose anything or improve, they would stay at the level 0. But those patients who would gain some motor functions would be above this 0 level. So and those who would lose would be below the 0 level. So as you can see, most of our patients actually gained something during the 14-month treatment period with nusinersen, and some of the patients actually gained almost 70% looking at the baseline before treatment. So this is a dramatic increase in what they could do, and it just shows that this medicine can actually really change the natural course of the disease dramatically. And another thing that you can observe here is that the younger patients generally tend to improve better, which means that this kind of underlines the importance of the fact that one should start treating the patients as early as possible. And there's also some data that treating pre-symptomatic patients can actually provide an almost normal outcome of these patients. But what is also was surprising to us to some extent, but also very comforting, was that even older patients, and not just like type 3 patients, but patients of all types, but also particularly type 2 patients, would gain something even though they were already in their teenage years. So the other treatment option that SMA patients have these days is gene replacement therapy. This is the drug that we have available in Europe now. I mean, it's been approved now in Europe, is onasemnogene abeparovec, or Zolgensma. This gene replacement therapy works in such a way that you take a viral capsid. So you take a virus which is changed in a way that it cannot replicate by itself, so it cannot reproduce itself, but it's still used to infect the patient, and it's capable also of infecting the central nervous system. But the infection here is a good thing, because this virus is carrying a normal SMN1 protein, and when it infects the tissue, it also drops the genetic information in the cell, and this cell is then capable of producing the SMN protein that is lacking in SMA1 patients. So this virus has been chosen in such a way that it can cross the blood-brain barrier, and it can actually leave the genetic material in the central nervous system where this genetic material is required. Some of the problems that are related to this treatment are predictable. So because this virus does not only infect the central nervous system, which it ought, it also infects other tissues such as liver. The liver can actually get overwhelmed by this inflammation, and but this is a predictable side effect of the treatment, which can be treated. And after treatment with steroids for several weeks, these problems usually reside, so they go away, and only the beneficial effect of the treatment then stay with the patient. And I'm showing you here a study that was published in 2017, where they were treating patients with Zolgensma at a very early age. And what's really comforting in this study is that if you start treating these patients very early on, so before, you know, for example, 5 or 6 months, then you can see that many of the patients would either gain completely normal development, or the development would be really approach the normal development dramatically. And this is a very, it's a major improvement in the natural course of the disease, comparing it to the natural course of the disease in untreated patients. We already, I mean, in Slovenia, we haven't treated any patients ourselves yet, but now we have this capability, and we expect that we will treat the first patient sometimes at the beginning of next year. And the third medicine that's been available is risdiplam. This is a small molecule which also works similarly as nusinersen. It changes the way SMN2 gene is behaving, and this it helps in this way that by increasing the SMN level of this protein, it really stops the progression of the disease. And there have been several studies performed so far. Some were performed in the pre-symptomatic patients, and some in the symptomatic patients. And the data is still not very abundant, but it is showing that risdiplam is also very effective in stopping the disease progression. So to conclude, I see that I have run out of time. I would just like to summarize that you know, the costs of treatment of SMA patients, of medicine, not just for the SMA patients, but for the medicine as a whole, are increasing you know, over time and over the decades. And this is not just happening in the Western countries; it's happening all over the world. So we will have to have discussions on which medicines are better, which medicines is not as effective, and how we will prioritize some of the medicines. But when it comes to, you know, a particular patient, there's no doubt that you know, treating a patient with one of those medicines can be really, you know, a life-changing thing. So this is a girl. This is our first baby girl who was treated with nusinersen, and she had the same diseases, the same type of the disease as the first girl that was on the video that we couldn't see, but still she lived well beyond the age of 1 year when that girl died. She's now you know, more than 4 years old, and as you can see, she's a very happy looking child. She can raise her hands with a cup and drink by herself. She can play with a ball, and she has a very you know, good fortune ahead of her. And this is unfortunately again a video which probably I cannot show, but this is a boy that we started to treat with nusinersen, but then the parents decided to also treat him with Zolgensma, which he received in the United States. And again, he was the one who was not able to move his limbs at all. When we saw him first, he could not lift them from the ground, but now he can sit independently. He's also a very, you know, happy looking child, and doing very well actually. And he's really capable of things that normally patients with his type of the disease would not be able to do. So to summarize, medicine is really developing at an incredible pace at the moment. There are novel treatment options coming, you know, and they will be available to our patients with time. So we have to change constantly as this landscape of treatment is changing as well. SMA now became a disease that we can treat, and we can really change the course of the disease tremendously. We have seen that treating our patients with nusinersen caused stabilization of the disease, but in many patients also improvement when compared to the baseline status. we are looking for novel treatment markers that would help us guide in this era where we have more than one medicine. So we will be more efficient in deciding which patients should get which treatment, whether combination of treatments would be perhaps better. Although at the moment we don't have any credible medical evidence for such combinations, but still in the future things will change, and by having certain markers, we will be able to decide in a better way for the benefit of the patients. And there's further research needed that will provide such data. So I thank in this spot to all the patients that were able to cooperate with us and to give and allowed us to put some of the data together to be able to show them today, but also to share them with the world, because this shared data will actually improve the stories for all of the SMA patients. And with this, I would like to thank you for your attention.
Thank you. Thank you very much for a very interesting presentation. We have one question to you. Could you tell us regarding the how many centers for treatment of SMA do you have in Slovenia, and what do you think? Do you cover whole pediatric population with nusinersen, or do you see that the access is still in some different reasons limited in Slovenia?
Yeah, so in Slovenia we are very lucky actually, because we only have one tertiary center and all of the patients are pooled in our hospital. This makes everything much easier, of course, because we have kind of a centralized view and everything is done on the same way. But I'm aware that
Right.
in bigger countries this would be impossible to achieve, and there will be differences between centers. So also Slovenia has been very very welcoming in regards to novel treatment options. So we were able to treat all of our patients, even the ones who had advanced stages of SMA. So we had 2 patients that were on permanent ventilation, which I know for a fact that is not the case in many other European countries. So all of our patients were offered nusinersen treatment. All of them actually started. Some of them decided to start with the treatment later on. There was one girl who was 18 at the time that didn't like the intrathecal application, and she decided to discontinue the treatment, but she was doing maybe better than most of our patients. So we will have 3 patients that will switch to risdiplam at the beginning of next year. And we had one patient who was a candidate for Zolgensma treatment, but the parents decided that the beneficial effect of nusinersen was so good that they didn't want to change. So, and they decided to stay, with the treatment. So we'll see what time brings, but yeah, we'll try to keep up to date and bring all these novel treatment options to our patients, and then we will together decide what's best for them.
Thank you very much for your very interesting presentation. It's pity that we don't have more time for discussion, especially that I am from Poland. The situation is totally different, and bigger country, bigger problems. Now, I thank you very much for interesting presentation. I hope so to find time to talk maybe one day on these issues.
Have a good day.
Thank you very much.